Hello, everyone. I expect this room is going to fill up because everywhere I've turned, everyone said, oh, I want to go hear Dr. Zisook on the psilocybin. And so we might want to let people know in the room next door that we're getting ready to start. I can do that. No, we have people over there. I was kind of just giving them a heads up in the back. So we are beyond excited. And as I said yesterday, I'm beyond excited because I love that the psychiatrists today are looking at these optional treatments, and they're doing evidence-based research to find out what's working and what's not working. And Dr. Zisook is a distinguished professor of psychiatry at UC San Diego. He directs the UC San Diego Healer Education, Assessment and Referral HERE program, dedicated to preventing, reducing nurse and physician mental health stigma, burnout, and suicide. He serves on the Scientific Review Board and Scientific Council of the American Foundation for Suicide Prevention, Scientific Advisory Board of the Depression and Bipolar Support Alliance, and Board of Directors of the American College of Psychiatry. He recently served as the national co-chair of a 35-site VA cooperative study on treatment-resistant depression, PI of NIMH research study assessing treatment of prolonged grief disorder, and an AFSP-supported intervention study providing grief-focused psychotherapy for individuals who have lost loved ones to suicide, and UC San Diego PI on a recently completed multi-site assessing psilocybin therapy for treatment-resistant depression. Over his career, he has published extensively on treatment of depression, suicide prevention, grief and bereavement, and psychiatric education. This summer, he will receive the 2021, that was last summer? He received the Depression Research Award from the American College of Psychiatry. Now, let's give him a big hand because that is one set of accomplishments. Thank you.
It's this summer because of a COVID delay.
Oh, okay, all right.
Thanks. Well, thank you. I'm delighted to speak with you today on a subject that is really getting great popularity and enthusiasm and something we all want to know more about. I guess the screen is up. So first, my disclosure, I'm going to be talking about a study that was just completed that was sponsored by Compass Pathways, and I received support from that company for the study that I'll be doing. My other disclosure is, and I should have forewarned you before you showed up, is I don't see myself as an expert on psilocybin. In fact, from many of our hallway and lunchtime conversations, my understanding is that many of you have more expertise and personal experience with psychedelics than I have. So we're all here to learn together. My experience with it comes from my interest in treatment of depression and my frustration through the years of the inadequacy of our current standard treatments and the need to find something else. And so the psilocybin study kind of came to me, and I feel very fortunate to have been involved in this and now to continue to being involved in the development of psilocybin for the treatment of depression and other disorders. So why do we need things like psilocybin? Why go outside of the box? And the story is, and we talked about this yesterday at the panel, when I was a resident a few years ago, we had available to us antidepressant medications, Elavil and Tofranil, and we had the MAOIs, and we knew then that these meds were better than placebo, but they weren't terrific, and a lot of people couldn't tolerate them, and if they could tolerate them, a lot of people still didn't get better when they took them, and if they got better, they were soon to get worse again, even if they continued taking them. So we knew, and even when they worked, it often took several weeks before it started working, and during that time they suffered considerably and were at very, very high risk for suicide during that period of waiting for the meds to so-called kick in. So we needed to do better. We needed to have medications, and we knew this way back when in 1972 when I was a resident, that we needed treatments that worked more quickly, that were better tolerated, that worked for more people, and that when they worked there was an enduring effect. And in the 50 or so years since, we've developed lots more treatments and lots of new psychotherapies, but none of which work more quickly for more people with a more sustained effect. So we're still grappling for those same issues as we were 50 years ago, and I think that's where we need to be going and thinking outside of the box to begin to find the answers to those continuing perplexing problems with the treatment of depression. So there are some new, novel, outside of the box treatments that are increasingly available to us. That includes at the top of this, and these are all sort of overlapping medications. We have the MDMA antagonists. We heard about ketamine yesterday. We didn't talk much about S-ketamine, but another drug in that family that are not really psychedelics, although they have some overlap with the psychedelics. They're in the classification called MDMA antagonists, and that includes ketamine and S-ketamine. On the left of the screen are another class of medications, the 3,4 methyl N-dioxymethamphetamine drugs, for brief MDMA, better known to all of us as ecstasy or Molly, that are also outside of the box medications, not exactly psychedelics, but overlapping with the psychedelics. And then we have the pure psychedelic medications like ayahuasca, LSD, mescaline, and psilocybin. Well, and I'll be focusing my talk primarily on psilocybin today. Well, a few years ago, ketamine entered our toolkit. It's not yet FDA approved, but as we heard yesterday, it's widely used a lot because ketamine is a medication that's available and approved for other indications. It's an anesthetic. Psychiatrists are beginning to use it more and more for depression. Ketamine, I don't think, is ever going to be the answer. It's an IV drug. It has a lot of liabilities associated with it. It in itself is, I don't think, going to be the breakthrough med to change our practices, but it created a paradigm shift for us. No longer are we stuck with the meds that continue to just work at serotonin, norepinephrine, dopamine, but we have meds that work in a very different way and begin to work more quickly and maybe in a more sustained way. So this is just a summary of 5 meta-analyses looking at the short-term antidepressant effects of ketamine, and in each one of them there were very, very robust improvements in depression within a day or two, which is totally different than we see with the antidepressant medications. So the meds, again, the ketamine MDMA antagonist and also a glutaminergic inhibitor, different than we see with the standard antidepressants. It has a very rapid onset of action for both unipolar and bipolar depression. The benefits of a single dose may last for, depending on what study you're looking at, 3 to 14 days after a single infusion. So we don't see that with an antidepressant. You don't take one drug one evening and then get better immediately and stay better for the next 2 weeks. That's just not the way drugs work. It's the way ketamine works. Some studies have found a very, very rapid reduction in suicidal ideation occurring within an hour or two. And think of that now as an addition to our toolkit in emergency rooms, where somebody comes in a suicidal crisis. We have a medication that will get them out of it within an hour, where maybe they can go home again and get into some longer-term treatment. Well tolerated. Side effects tend to be fairly benign, fairly transient. Okay. The son of ketamine, or the daughter of ketamine, S-ketamine, it's a metabolite, is the first FDA-approved out-of-the-box treatment for treatment-resistant depression, and it also has an approval now for major depression in individuals who also have suicidal thoughts and behaviors in their presentation. It's not approved for suicide reduction. It's approved for depression in individuals who are suicidal, which we think probably helps their suicidality. This is one of the key studies of S-ketamine, looking at the intranasal S-ketamine given twice weekly for 4 weeks, in addition to continuing the standard medication they're on. So the approval is as an augmentation. It's not a standalone, taking it with the antidepressant that you're already on. And here there was significant improvements in the rating scale, again within the first day, lasting for several days, and you can see the star here at 11 days. So the effects were significantly better than placebo as long as 10 days after starting treatment, but that kind of wears off over time, and the difference between placebo is not as apparent 2 weeks or 3 weeks later. So continuing treatment with S-ketamine would probably make sense, and we're beginning to get longer-term studies of the sustainability of the effect as long as you're taking the medication. The next outside-of-the-box treatment that I think is really a major, major breakthrough is MDMA, or again, ecstasy, Molly, along with psychotherapy. And because of some very, very robust initial small pilot studies, the FDA approved this for breakthrough status for the treatment of PTSD in 2017. Breakthrough status is something drugs don't get very readily. The vaccines got breakthrough status because preliminary data suggested they were more effective than nothing, and that the public health significance of having them available quickly was great. That was the same issue that allowed breakthrough status for MDMA for PTSD, and studies have been going along. MDMA has effects which, in the context of a supportive environment and psychotherapy, begins to work within 30 to 45 minutes after dosing. Some of the effects include euphoria, a sense of well-being, increased physical and emotional energy, extroversion, trust, compassion. Notice that one of the effects of MDMA is it releases oxytocin, the social love hormone. And that's probably a critical component of its effectiveness in PTSD, regaining trust, regaining support, developing an empathic relationship, etc. Also, as you can see from the name of it, methyl dioxymethamphetamine, the methamphetamine strongly suggests it also has stimulant properties, which it does. And that's responsible for some of the effects, certainly some of the side effects like increases in blood pressure and heart rate and energizing effect, which again is all probably very positive in terms of the treatment of PTSD. And the bottom line here, I think, is really important, and that is, more than any other drug I can think of, our experience with MDMA really confirms the importance of set and setting. Same drug, given at a rave party, produces all sorts of effects, positive effects and negative effects. Same drug in a therapeutic setting, in a very supportive environment, can be a robust treatment for PTSD. So set and setting is so critically important in the way these drugs work and in the way we may harness their therapeutic effects. Okay. So again, the topic today is psilocybin. So psilocybin has kind of re-entered our toolkit. And it's not that we've just discovered it, obviously. It's been around longer than any of us, longer than me even. It was first documented found in cave paintings depicting shamanic use of mushrooms in what is now North Africa. The Mayan and Aztec relics have been found depicting the ritual use of hallucinogenic mushrooms. In the Aztec culture, these were known as God's flesh, and I think that's such a good description of the overwhelming spiritual positive effects that this drug can have in certain people in the appropriate set and setting. Okay. Also known as magic mushrooms or shrooms, research was going full hog in the 1950s and maybe early 1960s for not only the treatment of depression and addictions and end-of-life anxiety, but also psychoanalysts were studying it as a way to facilitate psychoanalytic therapies and maybe shortening the duration, from 5 years of every day on the couch to a far lesser time, assisted by psilocybin. The war on drugs that in part was initiated because of the popularity of LSD and in some cases the misuse of LSD and the unpopularity of Timothy Leary, for example, who is drop in, drop out. These drugs then became Schedule 1, including psilocybin, and all of that research is stopped. And its use as a recreational drug really decreased considerably during that time. It became illegal. But it has profound effects on emotions, cognition, perception, sense of self. The mechanism is felt to be a 5-HT2A agonist, and I know mechanism isn't as important, but it has serotonin effects, just like the SSRIs and other antidepressants. But the effects are a lot different than what we see with the SSRIs. There's been a huge surge in interest in psilocybin, as all of us know, in the past 20 years or so, where there are now several studies again being conducted, many of them to kind of look at brain function. So a lot of fMRI data is looking at what this does to the brain, but also potential use, therapeutic uses, predominantly for depression, but also for addictions, for end-of-life anxiety in terminally ill cancer patients. We've got a study at UCSD right now for eating disorders, anorexia, which is a really challenging to treat disorder, using psilocybin. There's a study going on now for healthcare worker burnout using psilocybin. I think that'll be an interesting one, and I suspect there'll be very positive findings that may affect many of us and people we know and work with. So psilocybin and other psychedelics share the same chemistry, the chemical ring, the indole ring, as serotonin on the upper left, LSD, psilocybin. They look very, very similar. And so it is in the tryptamine family of medications, like all of the other pure psychedelics. Okay. Psilocybin in the body is converted to a psychoactive metabolite, psilocin. Psilocin has other effects on serotonin, HT1A and HT2C receptors. Not sure what those do, but the effects are beyond the HT2A receptor. General effects, when taken orally, the onset is within 15 minutes to an hour. It usually plateaus within 2 to 4 hours. So one of the advantages of this relative to LSD, for example, is that it's shorter acting effects. And so if you take it in a protected setting in a doctor's office, you can go home 6-8 hours later and it's out of your system. Total duration about 4 to 7 hours. The after effects, the most common one is headaches, and in our study we saw a lot of headaches. They're usually mild. They didn't require Tylenol, but sometimes they did. and 1 or 2 Tylenol were all that was needed. We also saw a fair amount of nausea and a lot of fatigue. People were just drained at the end of the dosing day, but the next morning they woke up feeling good and energetic, so it didn't last. In general, no physiologic hangover or after-day effects from psilocybin. So what are some of the effects? Well, it divided into sensory effects and affective effects. And some of the sensory effects, a predominant one, and reason it's called a psychedelic, is visual hallucinations. They were very common in people who have taken psilocybin or mescaline or LSD, and certainly in our study in the people that got the higher doses. There's something called visionary reconstructionalism. So psilocybin helps our brains become architects and restructure the way we see things and the way we view things. There are synesthetic phenomena that are very common, such as the fusion of senses. Hearing colors would be an example of a synesthetic phenomena that we see. There's an enhancement of perceptions, a contour distortion, things become fused with each other, increased sensitivity to light, closed eyes visual, so even with the eye closed, you're still often actively seeing things that can come and go. There are also auditory hallucinations. They tend to be a little bit less prevalent and common than the visual, but not uncommon. Alterations in perception of time and space, past, future, present, can emerge often, and you go from one to the other, often unexpectedly and quickly. So there's a dramatic alteration in time and space that we see during a psilocybin journey. Sensation of buzzing in the peripheral limbs, which can be pleasant or not pleasant. Something called the recollection analytic stage, and I asterisk that because that's a new terminology to me, and I wasn't sure I'd remember what it is. But so the recollection analytic stage is remembering presumably forgotten or repressed thoughts, and then being able to sort of reanalyze and reconstruct those and put meaning into those. And those certainly were very common in the psilocybin experience that we had. And they last, so that the recollective analytic stage didn't go away after the psilocybin was no longer present in the body, but we saw people in the days following the psilocybin ingestion continuing to recollect things that they had forgotten and put meaning into those and incorporate those into their daily lives as needed. And if you've been looking at the world through depressive glasses much of your life and don't remember the better times, the happier times, the supportive times, the loving times, being able to have access to those can be profound as you move forward. Okay. There are also affective states, and the one that's most frequently described is what's called oceanic boundlessness. And I think we can all understand what that might mean. And that boundlessness, that feeling of one with the universe, one with our past, present, future, one with the people around us, one with the plants, with the trees, with the beauty of the world, was generally considered a very positive state associated with euphoria, heightened feelings of sublime happiness, a sense of grandiosity, alterations in time and space, as I mentioned, often giggling, giddiness, increased emotional sensitivity, 1 minute and the next minute profound anxiety, and then back to the giddiness and happiness. So that was kind of typical. So there's the oceanic boundlessness, but also what's called ego dissolution, and that's kind of a psychoanalytic term that's sometimes used interchangeably with the mystical experience. But the boundaries of the ego seem to dissolve, at least temporarily, which may be associated with intense feelings of fear, mild to severe anxiety, and confusion. And the goal of the therapist working with the patient during a journey is to help them not avoid the fear, not avoid the anxiety, but go with it, stick with it, see where it goes, take it where it goes. And tomorrow we'll talk about it and see how it fits into your life. And that's the experience people had. I must say, we had available to us in our study antipsychotic meds and anti-anxiety meds just in case. That was an FDA requirement. Never used them. And I don't think any of the sites doing the study had recourse to the antipsychotic or anti-anxiety drugs. People were able to go with their anxiety, live with it, and make sense out of it. It can, certainly, the psychedelics precipitate or exacerbate existing mental disorders such as schizophrenia or bipolar disorder. And in all the studies that I'll be talking about, patients with past histories of psychotic disorders, with schizophrenia, with bipolar, were excluded. That doesn't mean they might not have a niche in the treatment of psychosis or bipolar disorder in the future, and I think they will, but for now, the studies exclude those patients for safety reasons while we're studying its effect on depression. And again, that was an FDA requirement. Now, just some data that I think is just really interesting on the mysticism and sustained revelations. And some of you may have heard of the Good Friday experiment. Pankey at Harvard, he was a postdoc student in 1963. You might all guess who his mentor was, the infamous Dr. Leary. He studied psilocybin in order to really optimize the possibility of having a really mystical, profound experience. He studied it in theological seminary students, and to really maximize the effectiveness in this setting, he did the experiment on Good Friday. So this is the Good Friday experiment, where 20 theological seminary students either received psilocybin or nicotinic acid, in a protective, supportive environment. We're told to think about spiritual things. And the seminary students, to a person, reported positive changes in their attitudes and behaviors, not only on Good Friday and during Easter, but at 6 months and 25-year follow-up. And the experiences that were described include feeling a oneness with the world around them, with God, depth of faith, heightened sense of meaning, joy, beauty, increased appreciation of life and nature, increased compassion, tolerance, equanimity, and solidarity with others. Sounds pretty good. We'd like to sneak some of this into the waters of some people we know in Russia. And many of them recalled this as a high point in their spiritual lives. So that was promising results. In a more recent study, not with theological students, but with people like you and I, Griffiths at Harvard administered psilocybin, and in his control, it was a very active control, methylphenidate, Ritalin, in a double-blind study with 36 individuals in a comfortable setting. Subjects were told to focus on spirituality, look within themselves, strive for a mystical experience. And at 2 months, 2/3 of the volunteers who had gotten the psilocybin rated this experience as either the single most meaningful experience of their lives or within the top 5. And these tended to be sustained. And this is just some data from that study comparing those in the blue who received psilocybin versus those in the orange who received Ritalin. And the question was, how personally meaningful was the experience? This was 2 months after the session, and as you can see on the far left, the single most meaningful experience of my life, 12%. That more meaningful than their marriage, than when they met their spouse, when they had their firstborn child, when they were bar mitzvahed, most meaningful experience of their life. And over 50%, 55%, rated it as in the top 5 most meaningful experiences. Again, really kind of impressive data on the power of these drugs to alter our experiences in our lives. And it seems to have been sustained. So family and close friends were also queried after this study, and they reported noticeably positive behavior and attitudes in those subjects at a 2-year post-experience period, and I understand there's still long-term data being gathered for this study. So how does it work? And the bottom line in the summary of the next couple of slides is we really don't know. But we have some theories. And one theory is the phenomenology of the experience itself may be enough to alter the lives of some people, including those with a major depressive disorder. And so these are just some quotes that people have about the phenomenology, and I'll read them aloud. You're so used to being immersed in your day-to-day fog. This enables you to step back. Another quote. On psilocybin, it was as if all of I better read it up here, it's bigger. The concrete coat that you're constantly wearing day to day has been put to a side. You can see and feel things a lot more clearly. You're not immersed. So that concrete coat is broken through. I had such instant relief, I could make up my mind about things. What I want in terms of career, I had a clear mind. It lifted the fog of depression. This, interestingly, reminds me very much of a lunchtime conversation yesterday. You'll remember who you are, who had a very profound experience with a psychedelic, allowing an important life change to be clarified and to occur. And that's kind of an experience that commonly has. It was a change of state. To be stuck in that place of rumination and to be able to move out of it, it reconfigures you somehow. And I think of that state of rumination and depression, and I remember the slide yesterday of the ball of death from our Macintoshes, you know, that red circle. And that's what that state of rumination is like in a depressed person. Can't get out of it, can't do anything else. And this allows somehow you to, turn that off, reset the computer, and move forward in a different way. And these are quotes from an individual in a psilocybin study for depression before, during, and after. So before this psilocybin session, the individual said, I saw negative patterns in my life where if something bad happened, I tried to put it in the back of my mind, but it was always there. Okay? During the session, I was weeping, tears were flowing. It wasn't a painful crying, it was like turning on the taps, like a washing out. So allowing oneself access to those feelings they've been trying to block for much of their lives. And then after the psilocybin session, afterwards, I allowed myself to experience everything, even sadness. Now I know how to deal with my feelings rather than suppress them. Okay? So this is the goal and the ideal of psilocybin-assisted psychotherapy. Another biological mechanism of action, these drugs are known to promote neuroplasticity, allowing the brain to grow, to regenerate. And one way it does it is it actually increases brain-derived neurotropic factor, BDNF. Another way of thinking about what BDNF is kind of like brain fertilizer. If you have enough of it, the brain nourishes and grows. If you don't have enough of it, you're stuck in ruminations of depression. And it increases BDNF. It increases neurogenesis. Electrophysiologically, we see what's called cortical desynchronization, and that desynchronization is what allows for reconfiguration, reconnections, and increased connectivity. Volumetric changes occur, increased hippocampal cells in rodents who are given psilocybin, which suggests that maybe in the limbic system there's some regrowth in us as well. Decreased thickness of the prefrontal cortex with chronic use. So a lot of biological changes. And many of you have read Michael Pollan's wonderful book on how to change your mind. If you haven't, get it. And if you don't like reading long books, the New York Times and the New Yorker both have shortened versions of it, which carry the essence of what the book, I highly recommend it. He talks a lot about the default mode network of the brain. The default mode network is in the middle segment of this. Includes the medial prefrontal cortex, the posterior cortex, angular gyrus. Those words are Greek to most of us. But it's an important network of the brain that is active when we're restful, when we're awake, but not focused on any activities, not problem solving, not doing things that are fun or pleasurable. It's active. And it has been associated in people who are depressed with excessive rumination, that ball of death circling around. And the ruminations of a depressed person, I've always been depressed. I am depressed. I always will be depressed. Life sucks. People suck. I suck. The world sucks. Those are the ruminations of depression that are increased as the default network is blocking other thoughts and feelings from us. That's the default way a depressed person thinks. If you block that, you allow for other networks to open up, and like the executive network, the salience network, etc. And that's theoretically what psilocybin does by desynchronizing the default mode network and allowing us to access other parts of our brain. Okay. And this is, changes in blood flow. The top slide here is a depiction of changes in depression, improvement in depression that is correlated with increased blood flow to the amygdala, part of the limbic system, part of the emotional brain, during psilocybin. And the bottom one is a depiction of placebo versus psilocybin in terms of the interconnectedness of brain regions that occurs with psychedelic drugs. So a lot's happening in the brain. And more likely than just the phenomenology of the experience or BDNF increases or the circuitry is probably a mixture of all of them. And we're really not sure how they work or why they work right now. But it does something, okay? And this is I listened to a talk on psilocybin by Robin Cathcart Harris in 2019, and I copied his slides because I think he said it so well in terms of how I understand they work. And so I just want to kind of read from Dr. Harris. The effect has been described as psilocybin shaking the brain up like a snow globe, or rebooting the brain, providing new connections and deactivating connections that might have caused depression. Deactivating the default mode network, providing new connections. You take a globe that's got these little snow bits, and it's settled. The snow is all at the bottom. You can pick it up, you can shake it, and there's disorder there. But then the snow will settle down again, he said. And this is the principle of resetting or reconfiguring the brain, and its analogy that's being used to traditionally in the context of ECT. That's one way we explain why ECT works. It shakes things up. But it's also now in the context of some of the novel treatments that are being explored for, say, treatment-resistant depressions, like ketamine or psilocybin. The notion is that you take a system that's become entrenched in pathology, it's fallen into a pattern or patterns that aren't healthy, and those patterns have become reinforced for whatever reasons. And then you can introduce psychedelics, you can shake things up, you can work on revising or figuring, updating some of these patterns and likely the beliefs which they relate to, so you essentially revise your belief structure. And so that's how they work. And I want to move now to, and hopefully I'm not, I'm going to check my time, 10:26, okay. I want to move to some data from studies looking at psilocybin. The common pattern in all of these studies, though, is it's not just psilocybin. It's psilocybin in the context of intense supportive therapy. And the therapy is more likely than not a very critical component of the psilocybin experience. When I started this just a couple years ago, we were calling it psilocybin-assisted psychotherapy. The term is now being shifted to psilocybin therapy, as it's really unclear, is the way it works to assist psychotherapy. Is the kind of support given exactly what we think of as psychotherapy? But so psilocybin therapy is kind of a more integrated, encompassing term for the therapy and the psilocybin experience fused. I think of this as the quintessential biopsychosocial treatment, because the therapy would be relatively worthless without the psilocybin, and I suspect the psilocybin would act more like a rave party in the absence of the psychotherapy that's provided. So I think they work hand in hand, and I hope that this becomes a paradigm for the way psychiatrists are trained in the future. The psychotherapy, the PSI, the P is for preparatory sessions, in most studies, and in ours as well, there were at least 3 preparatory sessions before the psilocybin day. So around 3 hours worth of therapy to develop a relationship, develop support, a trusting relationship, get a history, and prepare the person for the trip itself. During the psilocybin experience, there's 6 to 8 hours of support, and provided by 2 therapists, not just one. And that allows the therapist to go to the bathroom during the 6 to 8 hours, or have lunch, and someone always being there with the patient. And their main task during that day is not to confront, not to interpret, not to interfere, but if they're silent during those 8 hours, that's perfect. But when they do intervene, it's really to help the person continue their journey and self-explore and go with it. If they're feeling anxious, to say, it's okay, I'm here with you. Go with it. Following the psilocybin day, the next day is what's called the integrative session, which may be the most important. That's at least 90 minutes spending with the patient to try and integrate their experience. What did you experience yesterday? What was it like? What would you learn? And to help them begin to incorporate aspects of that experience now into their day-to-day lives. And there can be follow-up sessions as well as needed. Okay, so that's the psychotherapy. The treatment concept includes the 2 therapists, as I mentioned, a very comfortable room with soft lighting and a restroom right there. The room includes, a bed, eye shades, soft music, and everything to really keep the person comfortable and at ease and facilitate their journey. So I want to move now into some studies that have used this psilocybin therapy and effectiveness. And the first one is a very small study, not on patients with depression per se, but this was cancer-related psychological distress. But one of the measures was a Beck Depression Inventory, and I picked this one out because it was done here at UCLA. Charlie Grove was the PI, and this was an early breakthrough study. Only 12 patients, very small study, double-blind placebo control, and what you can see on the top is, compared to placebo, there were positive effects lowering the Beck Depression Inventory for those who got psilocybin. And at the bottom, this includes people after they got the placebo, when they did then get psilocybin, so it's all the subjects together. We see profound effects that were early and that lasted for 6 months. So even 6 months after, in these patients with cancer, in hospice care, I guess it wasn't hospice care, it was cancer-related distress, continued to have lower BDI scores than the group that had gotten placebo. Cancer-related depression, another study, slightly larger study, using a low dose versus high dose psilocybin. So the low dose was the control group, and then a crossover at 5 weeks. And in this cancer-related depression study, what we see on the left are response rates, people who got at least 50% improvement on the rating scale. And we see with the psilocybin, much greater response rates after the high dose than the low dose. On the right are the remission rates. Remission rates are essentially the absence of symptoms. So a score of less than 6 on a Hamilton would be considered remission. Again, much greater remission rates with the high dose than the low dose. And in that study, again, at 6-month follow-up, there continued to be substantial improvements in the group that got the high dose compared to the group that got the low dose. So very promising early data on people who presented with cancer and depression and anxiety related to the cancer. This was the first study, controlled study, published looking at psilocybin therapy for treatment-resistant depression. And this one was done at the Imperial College in London. Carhart Harris was the PI. And initially, the publication had 12 subjects, and 8 were added later. And this is the summary after adding the 8 subjects. And what we see here are marked and sustained improvements in depression at 1 week and continuing to be present 6 months later. There were also changes in anxiety and anhedonia and other outcomes in this study. The response rate at 1 week was 67%, 58% at 3 months, which is considerable. That's somewhat higher than you actually would expect with antidepressant treatment given every day. This was psilocybin treatment, given once. Okay. This, I think, is even more interesting than the data, is those same 20 subjects were interviewed a year later, asking about their experience of depression and of the treatment. So 20 patients were interviewed with treatment-resistant depression, and 2 main themes emerged from the interviews. One was that the patients described their depression predominantly, there was a kind of consensus that depression was a state of disconnection. They didn't describe it necessarily as a state of morbid sadness or unhappiness, a state of disconnection from themselves, from others, from the world around them, that was often profoundly rectified by the psilocybin treatment. In addition, they were asked to describe previous treatments. This treatment-resistant depression, they all had previous treatments. And they described their previous treatments as mirroring their state of disconnection. That the treatments were, especially with meds, but even with psychotherapy, were often meant to decrease their anxiety, to distract them from their pain, rather than facing the pain and anxiety head on. And that the psilocybin experience was just the opposite of that. It's face and embrace all of your human experiences and go with them. So I thought that really does mirror. It mirrors the treatment I've learned to do for prolonged grief disorder, where a major part of what we do is, hey, face the grief, face the pain, and that can have profound effects. So, based on these small pilot studies, the FDA put magic mushroom on the fast track for depression treatment, and maybe the next out-of-the-box treatment for depression. I think it's a couple years away from being FDA approved, but it's moving there. A couple studies since it was put on the fast track, and I'm going to briefly go through these because time is running and I want to have some time for Q&A. This was a study on the effects of psilocybin for major depression. This wasn't just treatment resistant. It was 27 patients with major depression randomized to either immediate or delayed treatment. So there was an 8-week waiting list. After the 8 weeks, you could go on and get the treatment. And again, if you compare those who got the treatment versus put on the waiting list, dramatic improvements in depression, starting right away and lasting through at least the 4 weeks. It was well tolerated, no unexpected serious side effects. This study was done at Johns Hopkins. Another study, in that same study, they then followed people for an additional 12 months to get a year follow-up of what was happening, and they found that those benefits that occurred during the first 4 weeks were retained over a long-term 12-month follow-up period. No serious side effects, no participants reported the use of psilocybin during that year outside of the therapeutic setting. So it wasn't that there was this craving for more psilocybin. That didn't occur. And ratings of personal meaning, spiritual experience, and mystical experience after the session predicted increased well-being at 12 months. It didn't predict the improvement in depression at 12 months, interestingly, but it did predict well-being, which, after all, is what patients are really striving for when they're not looking at Hamilton Depression Rating Scale or those symptoms. They're looking at feeling better about themselves and their lives. Okay. This is another study, an important one, and 59 studies comparing it to a standard antidepressant medication, Lexapro. Okay, half the people got Lexapro plus the supportive therapy, half the people got the psilocybin plus the supportive therapy, and placebo medications instead of Lexapro. And the results in some ways were a little bit disappointing because it didn't dramatically do better than Lexapro. It did at least as well as Lexapro. And this shows the differences in terms of the mean change in the QIDS-SR, which was the rating scale for depression. And we see numerically it outdid Lexapro, but there was not a statistically significant difference or a clinically significant difference between the two. They both did pretty well. But in one case, it was taking psilocybin once versus daily use of a standard antidepressant, which we know helps. So in this study, it did at least as well. The study's been criticized for being too small. It was underpowered to find a difference. And some of the other measures favored psilocybin. But overall, it did at least as well as a standard antidepressant. Okay. I'm going to go really quickly through this one. This was putting together two of the studies that I just talked about. One, the Lexapro comparative study, and another, the open study of psilocybin for treatment-resistant depression. In those studies, fMRIs were also done. And the results of the fMRIs showed that number one, with the Lexapro, there was a significant relationship between decreases in brain modularity, which is the same as saying increases in brain integration, things weren't in their separate silos, correlated closely with improvement in depression, and that was seen with psilocybin, but not with escitalopram. So mechanism of action is different than we see with the standard antidepressants. And I'm going to leave it at that, and this is just more data on the biology. Because I want to spend a few minutes talking about the study that I just completed that is not yet published, but the data I'm presenting is available publicly because it was available in press releases that came out from the company. And this was the largest randomized study yet done. It was an international study done in the United States, in Canada, in several European countries that compared high dose, 25 milligrams a day, to moderate dose, 10 milligrams a day, to low dose, which was considered the control group, 1 milligram a day. And all of them got the same therapy. I entered the study thinking the drug company was making a mistake because the therapy was so profound that even with the 1 milligram dose, people were going to get much better, and you'd never see a difference. And as usual, I was wrong. Here's basically the overall results of that study, looking at the MADRS depression rating scale, and the primary endpoint was 3 weeks differences in this. And what we see significantly statistically and clinical differences between the high dose, 25 milligrams, and the low dose, 1 milligram. 10 milligram in between, 10 milligram didn't do better than 1 milligram. Again, I was surprised by that. The high dose one did significantly better than the 1 milligram dose at 3 weeks and also at 6 weeks. This looks at remission. Remission rates were considerably higher with the high dose than the low dose, and similar to the kind of remission rates we might get with daily antidepressant medication. Response rates also greater with the high dose than the low dose. with the intermediate dose in between. Sustained response, about a quarter of people responded by 3 weeks, were still in response at 12 weeks, and had been in response in between. So that sustained response of 24%. Those who had sustained response had lower depression scores during the entire 12-week study, had better quality of life during the entire study, had more positive affect during the entire study. Functional impairment was improved, work impairment was improved, negative affects were decreased, self-rated depression was improved, and anxiety was improved. Okay. Just quickly, side effects. There were more side effects with the high dose, like headache, nausea, fatigue, but they were relatively mild and short-lived. They didn't exist the day after the study. They were there during that study and easy to manage. The more important side effects, like suicidality, anxiety, were no more common in the high dose than in either of the other doses. I must say the patients who got the low dose and didn't have a mystical experience and didn't get better, I've never worked with such a disappointing group of people in my life. It really was, it was very difficult on the investigators and on the patients, because there was no access. There was no then ability to refer them to somebody to get psilocybin. The next study we're doing is going to allow open trial for those who don't have a good response or got the low dose, which is far more humane. Okay. There are still ongoing issues. What is the best psychedelic therapy? Would CBT be better than the therapy we have, or in addition, would that help? Do we need 2 people for 8 hours during the dosing day? That's unrealistic in a clinical setting. It's very expensive. Who will pay for it? How do we get the right settings when this is out in practice? What's the ideal frequency? In our study, we had 1 dose, 24% had durable response. If we had 2 doses a week apart, would we have 50% having a durable response? I think it's an open question. I think the answer is probably. What is the best dosing? How often should it be applied? And where would this fit in lifelong management for somebody who has what is a lifelong disorder, major depressive disorder, in terms of prevention of other episodes, maintenance of improvement after improvement, et cetera. So these are all very unanswered questions, which hopefully in the next few years we will have answers to. And I went longer than I anticipated. Do we have some time for Q&A, or did I eat up all of our time?
No, you have about 5 minutes for Q&A.
Good.
If anyone wants to go over there, some raffles will hold them off for a few minutes.
Okay, raffles will be held off for a few minutes. So brief Q&A, and it doesn't have to be a question. Comments, personal vignettes are welcome as long as they're brief. Yes?
Was Zofran or any medication for nausea used?
In our study, it was not used and it was not needed. The nausea was only during the day, and it was mild. People were allowed to take anti-nausea medications afterwards if they wanted, but I'm not aware that was ever necessary. So it was very short-lived.
Because the expense of the study so far, how far along are you with maybe getting insurance companies to say this is a good idea and that we're all in?
As far as I know, we're very far away. The question was insurance companies, because it's not approved yet. And I think approval, we're probably a good 3 years away from approval. We have to get the phase 3 studies, which are scheduled to begin in the next few months. And those have to go through FDA, et cetera. Once approved, I think the insurance companies are going to be a real challenge, and they're going to be very, very restrictive initially in terms of who's allowed to get it and what they will pay for. And that's going to be a problem. I think that's one of the realistic issues and I think that's been a problem with escitalopram, and that pales in comparison to the expense that this would have.
On the study you just described, what was the course of treatment? Was it once a week psilocybin treatment? How long did it go on for?
The study we used was 1 dosing. So you had your preparatory therapy. There was a 6-week screening period, 3 sessions during the 6 weeks, the dosing day, and that was it. and then more therapy afterwards. So the next study that is being planned, that will start sometime in the fall, will have a second dosing allowed for people that don't have a robust response, and or who have a response but have a recurrence during the time, and then an open label phase for people who haven't had a good response at all. But this study, one dose, one day.
All right, and this will be our last question. In your study, did you have people off of all antidepressant medications before they did the psilocybin, or were they also on an antidepressant medication at the same time?
Good question. The answer is yes, they had to be off in this study. And that was one of the really hard parts of the study, was during our screening period for people who were on a couple antidepressants at high doses, is tapering them off in time to get this. They had to be off of all meds for at least 2 weeks. A small pilot study has been done looking at people who stay on meds and get it. There were two issues involved. One was fear of serotonin syndrome, because it's a serotonin agonist, which can be a very uncomfortable, even dangerous syndrome. That was one issue. The other is the fear of the effects of an antidepressant may be blocking the effects of this particular medication. Neither seemed to occur in the pilot study. The results were very similar. It seemed very safe and effective. So in the next study that it's going to occur in the fall, there are actually going to be two studies going on in parallel. One for people who are allowed to continue on whatever antidepressants they're on, remembering that they've already failed that antidepressant, because otherwise they wouldn't be coming into the study, but they can stay on it. And one for people who are off of all meds for at least 2 weeks before entering. And we'll be able to compare. Thank you very much.
Okay, so why don't you go take